All right, so hello everyone. We're going to get the event started now, and people will join us as we go. I just want to start by introducing myself. My name is Michael Malouf. I'm a medical student at McGill University, and I'm the president of the Rare Disease Interest Group here at McGill. I'll be hosting today our 4th annual Rare Disease Day event. And today is actually a very special edition of this event because it's for the first time that we will be doing this event in collaboration with our chapters from Georgetown, Perelman, and Western University. And so I want to thank you all for making this possible today as an event across North America for the first time. So just to get things started, I want to give some general instructions. So for today's event, we ask that you please keep your cameras off unless you're going to be speaking or if you want to ask a question, and the microphone as well. A few other things. After each talk, we will be having a question and answer session. And so you can ask the question in the chat during the event, or you can ask it yourself and just unmute yourself, whatever you prefer. If you ask a question in the chat, one of the moderators will direct the question to the speaker after their talk. If you have a more general question, not directed to the talk itself, but just any general question for us, you can also put it in the chat and someone will get back to you. Finally, after every talk, we will be giving away prizes. And so for those who are sticking around, and we'll be doing it as a draw after each talk. So please stay tuned for that. We'd also like to thank the Student Society of McGill University for sponsoring this event. And really, I want to thank every one of you for attending. So one of our goals of rareDIG is to create a strong community for patients and families and researchers and all those interested in rare disease to learn from each other and to help raise awareness for rare diseases. And so each and every one of you today play a role in that. And so I want to thank you all for this. This is just a brief overview of the program. After this introduction, we'll be starting with the speakers, and we're going to have a 5-minute break at the halfway point, and we'll be ending with some closing remarks. So without further delay, I'm going to open it up for Gregory to introduce our first speaker.
Hi, everyone. Thank you all for being here today. I have the pleasure of introducing our first speaker for today, Dr. Kristen Hunt. Dr. Hunt is currently a pediatric resident at Queen's University in Kingston, Ontario. She holds a Bachelor's of Science in Microbiology and Immunology, a Master's of Science in Immunology and an MDCM from McGill University. Her experience with rare disease began when she was 12 years old and diagnosed with a rare autoimmune bleeding disorder called immune thrombocytopenia. As a rare patient herself, she wanted to raise awareness for her condition, which is why she first teamed up with the Platelet Disorder Support Association to help other patients with ITP. Since 2010, Dr. Hunt has held many roles with the Platelet Disorder Support Association, including fundraisers, sitting on the patient research panel, and starting a 3-day summer camp for kids with ITP. She then went on to become one of the founding members of rareDIG at McGill. This initiative allowed her to continue helping rare patients on a much broader scale. As past VP External, she established rareDIG as a student chapter of the National Organization for Rare Disorders and was involved in organizing past Rare Disease Day events as well as rareDIG's Patient Perspective series. So without further ado, Dr. Hunt, you have the mic.
Great, thank you so much for that introduction. That was very sweet. Let me just share my slides to start. If someone could just let me know that they see this okay. Perfect. All right. So honestly, it's a great honor to be speaking at McGill's 4th annual rareDIG Rare Disease Day event. And just to think that a few years ago, this group was simply an idea waiting to be brought to life. So today I hope to use my personal rare disease patient story living with ITP in order to highlight the inspiration and importance of starting a rareDIG group and the positive impact that it can have on future patient care. So I want to start off by briefly sharing my patient story with you, and I thought that this would be sort of more most effectively done by playing this short video that I created in 2020 in collaboration with the website mybloodmyhealth.ca, who invited me to share my story. So it's about 2 minutes long, so I'll just share that first.
Let's get your recipe again. Okay.
As a child, you don't think about how lucky you are to be healthy. My childhood was full of adventure. Being physically active was part of my identity. It never crossed my mind that there was something that could hold me back. Until that one summer.
Mom? Oh my gosh, what happened? I don't know. I woke up with all this blood on my face.
Okay, don't worry. We'll figure this all out. Let's get you cleaned up first.
I'm scared.
At 12 years old, I was diagnosed with immune thrombocytopenia, or ITP. It's a rare and potentially serious blood disorder that affects 1 in 8,000 Canadians, and I have been living with it for 16 years. ITP is an autoimmune disease where the immune system mistakenly considers the body's own platelets to be foreign and attacks them. This leads to a lower than normal number of platelets in the blood. Platelets are small blood cell fragments that help your body form clots to stop bleeding. What it meant for me as a child is that I could no longer participate in gym class, play contact sports, or go to amusement parks with my friends, all for fear of possible internal bleeding. So I had to learn to adjust my lifestyle to more lower risk activities. The uncertainty can often bring on a lot of anxiety, so I learned to keep track of my platelet count. The one thing that has kept me going throughout all of these years is my incredible support system. Although ITP used to be a negative part of my life, over time it has led to so many positive experiences. It even inspired my career path to become a doctor. Living with ITP is my reminder that no matter what, I have to make my health a priority before I can do the same for others.
So just to go off from that video, I have to say that the first few years after my diagnosis were quite lonely. And my family and I had never heard of ITP before, and I had a lot to learn about what it was, what my treatment options were, and how this was going to affect my life. And we also didn't know anybody living with ITP for reference. And being a teenager at the time in high school didn't help, as I avoided trying to explain to my friends and classmates what ITP was, because I didn't want to stand out or appear different in any way, and that was pretty isolating. Now, during these first few years, I was followed by a couple of different pediatric hematologists, but there was really only one that eventually referred my family to an organization called the Platelet Disorder Support Association, or PDSA. And this was the only organization in all of North America that supported ITP patients, and it happened to be based in the United States. And this was long before the time that I had Facebook or easy access to online support groups, but we did Google them, and their website mentioned an annual conference for ITP patients to meet each other and learn more about the disease from ITP medical experts themselves. So finally, in 2011, roughly 7 years after my diagnosis, I was able to travel to Boston with my mom to attend my first conference. And that weekend truly changed my life. Suddenly, I was surrounded by hundreds of other patients who had the same diagnosis as myself and who knew exactly what I meant when I asked them, so what are your platelet counts at? And it was during that weekend that I met my now best friend, Melissa, a fellow ITP patient, where we would go on to form an incredible bond and an unstoppable advocacy team. And even though she lived in California and I lived in Montreal, we made a pact to meet up every year at this conference to brainstorm new ways that we could get involved and help other kids, teens, and young adults struggling with ITP. In terms of our commitment to PDSA, the rest was pretty much history. Every year we found new ways to get involved, whether that meant organizing 5-kilometer walk-run awareness events, or sporting purple for platelets, or starting the first ITP Kids Camp alongside the conference program. And in 2017, I was even able to help organize the first Canadian ITP regional meeting so that Canadian patients could come together more locally and discuss new ways to advocate for awareness and support in Canada. So I hope that so far my story has demonstrated the positive impact that this organization was able to have on my life as a patient, and that it was made possible by just one physician taking the time to listen to my family's concerns and being aware enough to put us in contact with the right patient organization that eventually transformed my care and allowed me to further become my own best advocate. Now, as you may have guessed, my diagnosis with ITP and my positive experiences helping other patients through PDSA inspired my career path towards medicine. And when I eventually got into medical school at McGill, I remember sitting in one of my first year classes, and one of my professors put up a slide entitled Types of Bleeding Disorders. And on that slide, they listed numerous diseases, including immune thrombocytopenia. And I remember this feeling of excitement that finally my medical school class was going to be able to learn about my rare autoimmune platelet disorder. And there was a brief discussion, but then to my disappointment, the following slide quickly moved on to the next subject. And that was it. The disease that I had been living with since I was 12 years old simply got an honorable mention on one slide. Now, of course, as a medical student, I was relieved that I was not expected to know all 7,000 rare diseases that exist. However, as a patient, I could not help but feel let down that somehow my disease was not common enough to be taught more extensively to a class of future doctors. And so it wasn't long after this that I began to discuss some of my concerns with my medical student friends and colleagues. And one of my friends, Jessie, who you may know as rareDIG's founding president, couldn't believe how long it took after my diagnosis to meet another patient with ITP and find the right support group. So after much brainstorming, Jessie came to me at the end of our first year of medicine and asked me, Kristen, do you want to start a rare disease group with me? And of course, my answer was yes. And it was as if she had read my mind, because this was exactly the way I wanted to continue to broaden my advocacy efforts to all rare disease patients. And to our surprise, it wasn't that hard to convince some of our other colleagues to join us in starting this group. Now, once we had some buy-in, we had to do a little bit of research to see what were the unmet needs for physicians and healthcare workers treating rare disease patients. And this is just one example from an Australian study in 2017 that highlighted how 28% of practicing pediatricians felt unprepared to care for patients with rare diseases, and up to 60% of them said that rare diseases were not adequately covered in medical school. Similarly, from the patient side of things, there was clearly some identifiable problems as well. And this is portrayed in the study by Bose and al. In 2017 that showed that the most frequently reported stressor by some of these rare disease patients was their experience interacting with healthcare providers. And some of the concerns that were brought up included physicians that were unwilling to learn about the disorder or unwilling to work with the families to explore different management options, the significant lack of care coordination across multiple specialists, and unfortunately, the lack of empathy when conveying sensitive information to families. So this brings me to the traditional rare disease education model that we often see in healthcare education. Essentially, we are taught that when you hear hoofbeats, think horses, not zebras. And so we are taught that common things being common. And so medical trainees go on to believe that they are unlikely to encounter rare diseases in their professional careers. And this lack of awareness may also lead to negative attitudes about encountering future rare disease patients. And then, of course, these students go on to graduate as physicians and other health professionals, and may eventually be involved in policy making and determining what public health needs are most important. And this can result in rare disease patients receiving inequitable care and facing unique challenges that go far beyond their symptoms. So we thought what the solution to this problem is creating a group like rareDIG that specifically targets medical students and allied health professionals early in their training in order to sensitize them to unique and complex challenges faced by people living with rare diseases. And the idea is not to necessarily become an expert in individual rare diseases, but the goal is that when you hear hoofbeats, and it happens to be a zebra, that you can feel confident that you have the right tools and attitude to help this patient. Which brings me to the importance of teaching these specific attitudes in order to improve patient care, with the goal of producing a generation of healthcare professionals who are rare disease aware. Now you might ask, what kind of attitudes are we talking about? Well, here are just a couple of examples to name a few. And these are based on some of the challenges that rare disease patients, and then the type of attitude we would want to promote in healthcare professionals. So for example, rare disease patients often encounter misinformation from non-expert physicians. And so we want healthcare professionals to be encouraged to demonstrate humility and a sense of self-awareness of their knowledge gaps, and realize that this is okay as long as they're willing to take the right steps to address and close those knowledge gaps. Similarly, there's quite a bit of isolation for patients and their families. And so health professionals should be approaching this with empathy and referring them to the right rare disease patient organization. There's also a lack of prognostication and guidelines available. And so health professionals need to feel a bit of comfort with ambiguity and to hopefully seek expert advice that's appropriate for their patients. Similarly, there's often limited access and extreme cost of certain therapies. And so we want to encourage health professionals to become advocates for their patients and really take responsibility for figuring out how they can break down some of that red tape and make the case for why their patient should gain access to an important treatment. And finally, patients inevitably become experts in their own disease, but is often not always recognized by health professionals. So we really want to encourage the attitude of recognizing patients as partners in care and promoting shared decision-making. And although rareDIG at McGill was initially the first medical student-run rare disease group in Canada, it is now expanded to include students from all branches of healthcare. Because really, the circle of care for each rare disease patient does not just include physicians, but also nurses and pharmacists and researchers and allied health professionals like physiotherapists, occupational therapists, dietitians, as well as social work and counselors. And each player has an integral role to play. So equipping trainees in all of these fields with additional skills to tackle rare disease specific challenges will further contribute to more equitable care. Now, this aspect of patient care has become quite prominent for me as I continue my training as a resident doctor in pediatrics at Queen's University. Because for our complex rare disease kiddos that are often admitted to the ward, it really does take a village. And I chose this field because I wanted to work with rare disease patients regularly, knowing that children are disproportionately affected by rare diseases. And the time that I spent building and learning from rareDIG events early in my training has truly had a positive impact on my ability to provide equitable patient care. Now, just as a simple illustration of this, I wanted to share a quick anecdote of a rare disease patient encounter that I had during my first year of residency. So at the time, I was working in the urgent care clinic when I met a teenage girl who had a recent diagnosis of a rare cutaneous form of vasculitis that honestly I had never heard of before. However, I was excited for the opportunity to put some of those rareDIG tools to good use. And after a brief review of her chart, I realized that she'd come in multiple times with concerns about her uncomfortable purpuric rash on her legs, which was one of the main symptoms of her condition. And so when I walked into the room, she was accompanied by her father, who initially spoke in quite a hostile tone. And he explained that his daughter was very anxious about her rash, and they were still waiting to see the specialist in rheumatology for the first time. So I listened attentively to their concerns and asked a few follow-up questions to really get a better understanding of what brought them back in today. And really, it turned out that they had done some reading and were quite worried that her condition could affect her other organs, which I later read can be the case in the systemic form of her disease. And she was still undergoing some workup to confirm this. So it was clear that they had seen many doctors before getting to me and had been dismissed with their concerns quite a few times. So I excused myself to review with my supervisor and looked up her condition on a few of my online resources, including the NORD website, because I wanted to see what role could I play to help address those concerns and provide some reassurance in that short time that I had with her. So I came back to her with a few thoughts. I told her that we could send her for a few additional investigations that her rheumatologist would probably ask for anyways, but that we could probably get done earlier while she was still waiting to see them. We also referred her to a nephrologist to make sure her kidney function wasn't impacted and to hopefully speed up the process on that as well. And then I asked her if she was interested in having some more reading material for her to learn about her disease from reliable sources and whether the contact information for a patient organization was something she would be interested in. And her face lit up and she gladly accepted, and I provided all of that prior to her leaving. And by the time they were ready to go, her father's tone had transitioned to one of genuine gratitude and thanked us for all of our help. And looking back, the things we provided for them were actually really quite simple. But the key is that they felt heard and that something more was being done during that long wait to see the specialist. And all it took was maybe 10 extra minutes of my time, which sometimes can seem like a lot in an urgent care setting, but likely saved that patient and her family multiple unnecessary returns to the hospital. And that was probably one of the most rewarding interactions that I had early on. And so I made a promise to myself to keep building my toolbox even during residency so that I could continue providing that kind of care to my future rare disease patients. And so it's always with cases like this that I tend to think back to my own pediatric hematologist who first referred me to my patient organization, PDSA, and how very different my life would have been if I had never gone to that first conference and finally met other patients with ITP and was able to have my questions answered by ITP experts. And now that I'm on the other side of things, I want to be that kind of physician for my future rare disease patients. And I've learned so many valuable tools from my time spent building rareDIG and the educational events we hosted. And so I can now say that I apply those attitudes I spoke about earlier on a daily basis, and I have built much stronger patient relationships because of it. So I hope that I've demonstrated today through both my patient story and motivation for starting rareDIG at McGill that I have inspired maybe some of you in this audience, perhaps undergoing healthcare training yourself, to start your own rareDIG or become involved with your local version that may already exist. And I would go even one step further to petition your training programs to include rare disease teaching as a standard part of your program, because I can tell you from experience that your future rare disease patients will be forever grateful. So I thank you for your time and for listening, and I'm happy to answer any follow-up questions.
Thank you, Dr. Hunt, for the talk and for being here today. It was really informative, and it was really interesting listening to your story with rare diseases. So we do have a few minutes for questions. So if anybody wants to either unmute or you can send it in the chat or privately to me, I'll be happy to read them out. So we do have someone interested in knowing what your future plans are after residency, if there's any specific goals you want to achieve as an attending or any subspecialty you want to go into later.
Yeah, that's a great question. So I'm actually planning to apply this coming summer for a subspecialty in immunology. So I'm kind of continuing on the path that I first started out on. And I really want to be able to specialize in more rare diseases from an immunology point of view. So I hope that eventually when I'm a staff, I can actually implement some of this rare disease teaching, whichever medical school I end up potentially being an associate professor for. I really hope that I can contribute to future rare disease teaching for future medical students and other health professionals from that standpoint. So that would be sort of my overall goal for sure.
Great, and we also have a question, just more specifically, if you can give a little bit more detail on how you started rareDIG. So maybe so the person wanted to know maybe just a bit more detail of how the actual group came to be and the journey like after that.
Yeah, so initially rareDIG started off pretty small. Essentially, it was a medical student-run club that was within our medical program. But then we started branching out and doing some research on what patient organizations we might be able to collaborate with. And that's when we got connected with the National Organization for Rare Disorders. And I saw that we were able to sort of make our group as a student chapter of that. And by doing that, it provided so many additional resources and connections. And then we started reaching out to other patient organizations to have people come in as patient speakers. And then we came up with the idea of doing a bigger Rare Disease Day event where we could invite sort of leaders in the field. And then eventually towards the end, when we were sort of on the verge of graduating, we figured that if this group was going to survive past us, we really wanted to have enough people that wasn't necessarily just medical students involved in it. And so there was a lot of research students and other students from other healthcare professional programs that started to join rareDIG. And I think that's what's allowed for its success to live on past our initial group, and it continues to grow. And so having buy-in from multiple fields, I think, is really important, and also is reflective of future patient care, where again, it's not just going to be physicians involved in patient care for rare diseases, it's everyone else too. So
that's great. And we do have another question. They're asking if you have any suggestions for a future social worker in Montreal wanting to be more involved in understanding and advocating for rare diseases, and what would be the best angle of approach to get involved as a current student?
Yes, that's a great question. I think from social workers, I've worked with them so closely in pediatrics, and they're such a great resource because there's often so much red tape in figuring out how can I get this patient the adequate resources for home nursing support, or how can I advocate for a specific treatment. And oftentimes social workers are the ones that end up having some of those answers because it's more part of their training than it is ours. So I would say from that point of view, there's a bit of a focus that social work students can actually take for educating themselves on what's the best way that they can use their field to promote patient care for rare disease patients. And then I would say to try to look inside your university or wherever you're studying, if there's other people within your social work program who are interested, again, either forming a group or getting involved in a group that already exists, and then trying to sort of assess out what are the gaps in knowledge that social work specifically can target, and then going from there. And I would say that's kind of the approach that I would try to take from a social work perspective.
That's great. That's all the questions I got for now in the chat. So if anybody has any final questions, maybe in the last like 2 minutes, you can feel free to send them to me or unmute.
I just wanted to say thank you so much, Dr. Hunt, and I think it is very telling how far this initiative has come, in just 3 or 4 years. So thank you so much for starting this group, and we're excited to see it continue for many generations.
Yeah, thank you so much for having me today.
No problem.
I'll unshare my.
And we did also get a specific question about some of the references a student was interested in looking into it. So if you have maybe a contact like email, students can contact you for some of those things. Maybe put it in the chat if you can, or send it to one of us and we can send it out to everyone.
For sure. Yeah, please email me with any questions, follow up from this talk. Thanks so much.
So the winners of the Uber Eats draw will now be put in the chat. So please have a look at the chat for those of you who are interested to win the prize. And these will be announced after each talk, like we said. So now we will go on to our next speaker. I'm going to allow the moderator from Georgetown to take over now.
Hello, everyone. To introduce myself, my name is Robin Yoon, and I'm from Rare Disease Interest Group of Georgetown University School of Medicine. We'll be giving us a talk about rare disease as a unique field of medicine. Dr. Marshall Sommer is the Margaret O'Malley Professor of Genetic Medicine at George Washington University Medical Center, and he is the Chief of the Division of Genetics and Metabolism at Children's National Hospital in the nation's capital, Washington, D.C. Additionally, he launched and directs Children's National First Clinical Rare Disease Institute, which is the largest clinical division of its kind, treating over 8,000 rare disease patients per year. Dr. Sommer currently chairs the National Organization for Rare Disorders, NORD, Scientific and Medical Advisory Committee, as well as co-chairing the research committee for the Rare Disease Diversity Coalition. His research focuses on adapting knowledge from rare diseases to mainstream medicine. And apart from his academic appointments, he works to develop a next generation of physicians in the rare disease space, like many of us medical students gathered here today. Needless to say, his pioneering work in providing care for rare disease patients has left a huge positive impact and is continuing to do so today. So if everyone will, please join me in welcoming Dr. Sommer here as he comes on. And just as a friendly reminder to those who just tuned in, we'll reserve about 10 minutes at the end for questions and answers. Dr. Sommer, you have the call.
All right, thank you very much, Robin. That was a great introduction. I very much appreciate it. Dr. Hunt, I may still have to come after you and try to recruit you for our genetics fellowship somewhere. So first off, this is my part of my team. We have about 45 folks in the program here in the Rare Disease Institute, but when we were on our last Zoom call, I said, hey, can you give them all a thumbs up for this? I've been doing rare disease and genetics since about 1985, so kind of been fun to watch that. And it's kind of funny, I hadn't thought of this until very, very recently, and I was on a phone call with a colleague in Africa, It was around Rare Disease Day, and they were asking me, why a zebra? Why do you guys use a zebra to represent rare disease? And realized it's kind of an inside story from hoofbeats and zebras and horses and things. And he said, zebras are common here. So I asked him, what do they use? And they use DNA. So I told him that wasn't very exciting and we were going to stick with zebras. Also, I want to encourage you in these student activities. As I'm the past board chairman for NORD, one of the things we want to encourage and we want to continue to encourage, we've got lots of educational activities, lots of things, are these student activities. And our partners over at Georgetown are awesome. That's where we do all of our rare disease liver transplants in partnership with the team there. So first of all, thank you for asking me today, Robin. I really appreciate it. So what I thought I would do is kind of bring you up to speed on where's the field of rare disease, kind of from a global perspective. What's the impact? What's going on? Because we've got a little bit of a naming problem. When you use the term rare disease, policymakers, insurers, payers, hospital executives, everybody else tend to go yawn. But it's actually grown. And actually, currently right now, there's really over 8,000 different genotype, phenotype descriptions that we would list as rare disease. To give you an idea of the scope of how much this has grown, when I started around 1989, we could really identify under 100 conditions. Now we can do over 8,000. And actually, if you do the math on this, that means we're describing about 10 to 11 new conditions every single week. A lot of this came as a result of the Human Genome Project. I had a lot of fun being a part of that. When we got the sequence finished, we thought we'd have it all figured out. What we didn't realize was the story was just beginning. As we describe these thousands and thousands of new conditions, we have to understand them. We have to figure out how to treat them, all sorts of things that we have to do. So there's only currently about 600 FDA, and I apologize to my colleagues in Canada. I'll just use the US FDA as a reference guideline here, but we tend to parallel a lot on that, but only about 600 with an FDA approved therapy. Now, that doesn't mean we don't treat the rest of these patients. It just means that we don't have anything that is targeted as a specific therapy for their disease. And those 600 probably expand to about 800 or 900 when we look at medications we can use across multiple diseases. The other thing we're seeing is better survival. This is a great study out of Spain in 2018, where they've shown that if you go back to 1999 and you look at patients with rare congenital abnormalities, the death rate has been going down consistently every year. And this is a trend we're seeing globally. Down syndrome, kind of one of the more common in the rare disease. I would say it's medium rare or maybe not very rare. But when we look in the 1980s, average life expectancy was 25 years. Now it's approaching 60. It's going up every year because of all the things we can do now for these patients. Sickle cell anemia used to be something we would see death around teenage years. Now actually life expectancy with all of the new therapies, whether it's bone marrow, whether it's hydroxyurea, and then there's some of the new exciting gene therapies coming along. Just a ton of stuff going on there. Cystic fibrosis, another great example. Used to be a death sentence to have a diagnosis of classic cystic fibrosis. Now these patients, the life expectancy increases almost a year every year because we don't have a back end on it because we're doing so many things for these patients. And these improvements aren't just because we developed a new therapy. It's actually because we've got organized people like you someday who will be talking to each other and pulling together, what's the best way to treat this patient? What do we learn? What do we know? In the information age, rare disease has benefited more than any other specialty through the sharing of information. Remember, the classic physician was supposed to know everything about his particular specialty. Those days are gone. When you're doing 10 new diseases a week, if you are not using information technology, if you are not networking with colleagues, you are not taking good care of your patients. And actually, one of the things I would postulate, and this seems to be a growing trend, I came up with this a few years ago, we used to call it genetics and medical genetics. The thing is, genetics is now used in every field of medicine, whether it's cancer, cardiology, take your pick. They're using genetics for both diagnostics, for treatment selection, things like that. And I was like, okay, well, what's the role of the medical geneticist these days? And it really is care of these thousands of rare diseases that don't have a classic home. So what I would postulate is that rare disease has actually become a unique field of medicine and science. And we're seeing this more and more. In fact, we'll probably see a big institute at NIH in the next few years around rare disease as its own unique field. Why? Conditions are mostly genetic and lifespan in nature. A lot of healthcare problems are transient, even cancers. Hopefully they come and they go. A genetic rare disease, you are going to have that change your entire life. Diseases aren't limited to an organ or a system specific. We have to deal with every organ system, every aspect of healthcare. A colleague of mine years ago said we are the world's most highly specialized generalists, which makes it a fascinating field. But also the information from which we develop treatment guidelines, patient care things. If you're dealing with hypertension, you have data on hundreds of thousands or millions of patients. If you're dealing with a rare disease, you may have data on only 5 patients. That may be the world's population size for that disease. So we have very limited incidence data, very limited outcome data, and very limited natural history data. And this is compounded by the fact that the genetic variations that underlie these diseases can give you different levels of severity of the disease. So not only are there not many patients, but they actually tend to have a lot of differences. We find that patients and families are often the best source of information. I'd be willing to bet that Dr. Hunt knows more about her condition than almost anybody else she encounters, including seasoned hematologists. Also, the care model, well, and immunologists too, the care model is complex and involves multiple specialties. When we look across specialty use in the rare disease population, it's higher than any other group of patients. And care expertise is limited. And I'll circle back to that and why I want to talk to you guys so much today and why this is so important. So another trend we're seeing is that common diseases are breaking down into smaller and smaller groups that resemble rare diseases. Take breast cancer, 150 per 100,000 incidents per year, 30 molecular subtypes, however, that break those down into groups of around 8 to 10,000. That's actually a rare disease size model. We're seeing that with prostate cancer. We're seeing that with a number of different conditions. So the techniques, the things we're developing in rare disease actually are becoming more and more applicable to the general field of medicine. So here's some experience from Children's National, where I've been for the last 12 years. We looked at about 1.5 million visits to the institution over about a 3-year window. And what we found is that if you come just once to a children's hospital, there's a 12% chance you have a diagnosis of a rare disease. And we used ICD-10 codes for rare disease. If you don't know what ICD-10 is, don't worry, it's basically a coding system for what your condition is. If we looked at patients admitted to the hospital, it was 18%. If you came to a children's hospital more than once, 32% chance you've got a rare disease. That doesn't sound so rare anymore, does it? That actually makes it one of the most common diagnoses at a children's hospital after trauma, asthma, and infectious disease. So it's really in the top 4 there. When we looked at the financial impact, there were over $4 million in physician charges for these patients, but in facility use charges, remember I told you they use a lot, was over 74 million. Most common thing we saw was Down syndrome, followed by different varieties of genetic rare disease autism. And if we look across the US, this is a great study that Sean McCandless did back in 2004. When they looked at just inpatient admissions at their hospital, 34% had a clear genetic condition. 51% of the hospital bills, though, were from those 34% of patients. And there was some genetic determinant in almost 81% of the patients in the hospital bills. If we looked at the cost of treating orphan disease, this is a topic that comes up a lot. It's not all about the money, but these are some of the things we have to keep in mind. 2017, average cost per year for a rare disease patient was about $84,000. For a regular patient is about $15,000. So actually the multiplier is only about 4 or 5-fold. A lot of folks were saying it was 10-fold, 20-fold, 30-fold. So while $84,000 is a lot of money, it's not nearly as much as we thought it might be before we started doing these estimates. So what are we doing therapeutically? Lots of new options in the therapy world. Organ transplant, of course, liver, bone marrow, all kinds of things. Enzyme replacement for our lysosomal storage disorders and other diseases. We can now give you back a functioning element of the enzyme. We have lots of small molecule therapies and continuing to develop new ones. Substrate and product, that means we can change things, try to make sure that what's going into a system that you've got too much of, we try to find ways to reduce that, or we try to hijack different enzyme systems. Bacteria, interestingly enough, bacteria in the gut are something we look at as a therapeutic option around rare disease. Messenger RNA manipulation, gene therapy. Gene therapy has been around a while. I started in this field, like I said, in the mid 80s, and gene therapy was with us then. It was always 5 years away from being mainstream therapy. And in 2022, I would say it's still 5 years away from being mainstream therapy. I mean, there's a lot of promising work going on, but it's still not quite there. And then a whole new series of research things around gene correction, going in and actually changing the missing code back to the way it was supposed to be. And even simple things like dietary manipulation. Phenylketonuria, one of the commoner rare diseases we see, we can treat a lot of that just simply by reducing an essential amino acid in the diet. So lots of things to do there. When we look at the number of drugs approved, there was actually something that happened in 1983 called the Orphan Drug Act. And Canada also has an Orphan Drug Act that gave incentives to companies to develop therapies for rare disease. Because otherwise, why would you go spend hundreds of millions, and the average cost for getting authorization for a new drug is about 200 to 400 million on average. Why would you spend that money on maybe 100 or 1,000 patients? This gave them real incentive to do it, and look what happened, it's exploded. So we're getting actually 50 to 60 new drugs a year for rare disease. And you say, well, aren't there a lot more? That's almost 50% of the drugs approved for any disease at the FDA each year. So the Orphan Drug Act has been so successful that it's now becoming the bulk. A lot of those are for rare cancers, but actually over half of them for other rare diseases. So lots going on. When I talked about gene therapy, there are currently over 400 active gene therapy protocols open at the FDA. So it's an incredible time to be in the field. I mean, opportunity like you would not believe. When we look at the distribution of resources and physicians to care for, as you might expect, they cluster Europe, US, and Australasia probably have the biggest numbers there. I don't have good numbers for Japan, but Japan's got a fair number as well too. If we break that down, so in the US and Canada, so about 1 geneticist for every 250,000 patients. Latin America is about 1 in a million, 1 in 1.25. However, in Africa and other developing countries, it's about 1 in 4 to 5 million. So in other words, it really does not exist much beyond just kind of a wave. And you can say, that's horrible. How are we going to fix this? Well, believe it or not, that 1.25 million in Western countries is still well below what we actually need. We actually need something around 1 in 100,000, 1 in 50,000 to actually meet most of the needs right now. So there are needs everywhere. So if you want to look at a place where there's job security, by golly, there's job security in the rare disease field. So what are the challenges we're facing right now in rare disease? We've got more diseases we're diagnosing with longer survival, which means there are more patients and more patient years that we're dealing with. We've got an explosion in treatments because of the Orphan Drug Act and just awareness around rare disease. We've got a diagnostic explosion. The cost of a whole genome is, in my career, has come from over $2 billion down to about $1,000. That's, you tell me anybody else that's got a cost reduction like that, I'd love to meet it. Patients are going from acute to a chronic model. It used to be that we would meet patients, diagnose them, wish them well, but there wasn't much we could do. Now we have options for almost everything we're dealing with now. Geographic distance and access disparity is one of the biggest things we're dealing with. We have patients in areas where there is not an academic medical center, there's not a genetics program, that these patients don't have good access. And that's one of the things we've made the most impact on in the last few years. The financial impact on the health system. We used to fly under the radar because while our patients cost more, there weren't that many. But now that we're becoming a significant portion of the patients being seen in the healthcare system, this is really starting to attract notice. And what we have to figure out is how are we going to afford all the things we're doing. And then our workforce challenges, particularly in pediatric specialties, but particularly in medical genetics. So I love a challenge, so challenge accepted. So what are we doing? Well, for one thing, you'd be surprised just how much impact collaboration has. But also, we have a better opportunity to use new care models than any other field in medicine. And a lot of that's going to devolve around technology and involving primary care providers. Over the last 30 years, there's been a real trend to push something that's not just complete bread and butter towards subspecialists. And we've really underutilized our primary care, our family practice physicians, our primary care providers, our pediatricians, our internists, and that's got to stop. One of the things we have to do is empower those primary care providers to work with their rare disease patients. I'm going to tell you about some of the ways we're looking at doing that. So around collaboration, of course, there's CORD, which is the Canadian Organization for Rare Disorders, who I work with a lot. There's NORD, the National Organization for Rare Disorders, which we need to rename so it's not quite so US-centric. I'm also doing a lot of work with the World Health Organization Collective Global Network. We're trying to figure out how do we deploy resources around the world. There's a global commission to end the diagnostic odyssey for children with rare disease, which is the worst, makes no good acronym and is just way too long, but we haven't figured out a better thing to call it yet. The other one with a bad acronym is International Rare Disease Research Consortium, but all of these are designed around trying to find new ways to treat patients, new ways to get care and services. One thing we've done that I think kind of makes some sense is we break the patient journey down into steps, symptoms and findings, engaging the medical system, what I call the diagnostic loop, where some patients may get that diagnosis very quickly, but sometimes it takes a couple of cycles of testing. And that's where some of our access issues have really hurt our patients, leading to years before they can get their diagnosis. Once we have the diagnosis, we go to treatment and monitoring. Sometimes it's an established therapy. Sometimes it's experimental, and then we move into the chronic management phase. And there are things you can do at every single step of this pathway to improve the process. We're trying to push early things out like facial recognition, triage apps, using machine learning. I don't like the term AI because that implies that there's somebody behind there thinking about what's going on. But machine learning is a great tool that we're starting to use in rare disease more and more, simply because of the workforce shortages. Community education, patient access, groups like the student groups that you're in right now, you guys make a difference. Because if nothing else, no matter what you go on to do, you're going to remember about these rare diseases. And sometimes just thinking about them gets you started. And then just changing the whole visit up. The classic visit where the patient comes, sits in the waiting room, gets taken back to a room, sees the doc for a few minutes, maybe the genetic counselors, maybe someone else. They go out with a couple of tests to do or a new prescription and then come back. That model just really doesn't work. Most genetics practices in the US have wait times of 10 to 12 months. That makes it almost irrelevant to that patient. We can use other things to do that better. So there's lots and lots of things we can do around here. Telemedicine is one I'll talk about real quick. And the benefits for the patient up through 2019, telemedicine is very rarely used. Why? A couple of things. One, you have licensure issues across boundaries. You have people just were like, well, what is this thing? Things like that. So we got to run the big experiment back in 2020 when COVID hit, because suddenly our patients could no longer safely come to the hospital, but we still needed to see them. So we started seeing patients where they were rather than bringing them in. We were working on this beforehand, but the hospitals were resistant, and that's pretty much been everywhere on the globe. But now we're seeing a lot of advantages. One thing, it decreases wait times. We can see a patient in a couple of weeks as opposed to a year. It allows simple issues to be addressed quickly. So patients are staying out of the hospital. When we started using telemedicine aggressively, we saw a 25% drop in admissions for our patients. 25%. That is a ton of health that we just say, well, and why? Because when you bring patients into the hospital that didn't have a virus, great place to get one is in the hospital. It also saves clinic slots for patients that need to be seen in person. The other thing we found, there were some patients that really benefited from a home visit, like patients with autism. I had two parents recently in tears because they didn't have to bring their kids into the hospital. We could see them at home. And she said, if I had to bring him in, he'd tear up the room, he'd be hitting you, and you'd have no idea what a sweet child he is. And I actually got to meet the patient as he really was in his home, which was actually a pretty sweet kid. He just didn't make great eye contact, but he hated new situations. So lots of things. And our dietitians for our inborn error metabolism patients can actually do freezer viewings with the family. And some of our patients have actually had much better compliance because now we're going and looking to see what's in the refrigerator and if they're eating the things that are actually on their diet or not. And also we can address small problems faster. You can set up a telemed visit really quickly as opposed to having to take a day off, come into the hospital. Sometimes we only need 5 or 10 minutes. So it's done a great thing there. It removes barriers to care. For a lot of our single working families, they can't take a day off and come to the hospital. They may not be able to miss work from that job because that's going to maybe cost them the job. Whereas now we can see them quickly at home. They don't necessarily have to take off from work. For kids who are at school, we found a lot of families just drive over to the school, bring the kid out to the parking lot. We see them in the van or the car with the parents, and then we're done and they're back in school. Actually, some of my patients don't like that because then they don't get the day off from school, but you know what? I can live with their dislike of that. The other thing is it's easier to network multiple specialties on telemed. We can bring in multiple specialists on screen. They can rotate in and out as we're doing these things. We've done a lot of Zoom medicine in the last couple of years. So just to kind of show you, that's what happened with how much telemed. Oh, no, my apologies. The graphics did not come through okay on that. Anyway, the month before is the small graph down here. The month after is what we did with telemedicine. So we actually went up tenfold on our visits. Patient impacts, a couple of other things we noted. Separated parents, particularly military families, could both attend their child's health visit. High frequency visits were better. Less work and school time loss, all the things we just talked about. And we were kind of wondering, what did the patients think? They loved it. They were like, why haven't you been doing this for years? The place we had the biggest struggle was with our non-English speaking families. Our Spanish families had a little more trouble with that, but what we did is we went out and hired a patient navigator who would get on the phone with them, get them onto the visit, and stay in and make sure that they knew how to do the connection. Once they did that, after that, it was easy. So it really was a great system for that. What are some of the other things? I told you about machine learning. So we've actually now got software we've been developing here at Children's where kind of the 5 top common dysmorphology syndromes we can do from an iPhone or an Android phone. Boy, it almost gave a product endorsement there. We can do it from any good smartphone with a good camera, from a good image, and actually have about 95 to 98% diagnostic accuracy. We developed this because we were doing clinics in places like Uganda, where they really couldn't even afford to do a karyotype or a chromosome study on the patients. That would have been the clinic budget for the month. But we always found there was somebody in those clinics who had a smartphone. So by being able to build off of that, we can now provide low cost or almost free diagnostics for patients in areas before that had nothing. And this does impact these patients. Diagnosing Down syndrome means you need to look for thyroid. Treating hypothyroidism is very cheap. You can also recognize the heart disease in those patients earlier, treat them. So it reduces the cost of care for those families and the burden on the system, even in areas where there really isn't a sophisticated medical system. We've also been working on building at-home testing devices. That's the next thing is if we want to keep our patients out, then we need to try to keep them from having to come to the lab. So we built a home ammonia monitor for some of our metabolic disease patients. The final version looks a lot slicker than this, but basically in a few minutes, a patient can do something normally they would have had to drive hours and sit in an emergency room to get tested for. So lots of things like this. There's new blood drawing apparatus. It's basically a little thing that you put on your arm, and in 15 minutes it can draw 1 to 2 cc's of blood painlessly. So for our little kids now, we can actually do our testing that much better. So lots of things. This is the last one I'll tell you about before going into questions. But so how do you teach people how to treat these patients? We have a massive software project going on right now called RareCAP. And like I said before, my colleagues in Africa will ask me why it's got zebra stripes on it, but they're just going to have to live with it. What we're doing there is doing crowdsourced clinical protocols for these patients. So people who are working regularly with these patients will have a base protocol, though, that they can make margin comments, and the moderators, if the margin comments are liked by enough of the folks, can actually pull that into the protocol. Because the classic model of collecting large amounts of evidence on how to treat something before you start coming up with a clinical guidelines just does not work in this field. This will allow those things to come in, but it also gives you a good starting place. And these are done in a way such that a good clinician can use them in almost any setting. So how do I view the field? So some people view the glass as half empty and half full. I view it as always full. There's just, it depends on how much water and how much air you've got going on there. So I'm as excited about this field as I have ever been. I think there's opportunities for providers are outstanding. So if you get a chance to come into this as a field, you will find more rewarding patients than any other field of medicine. I can tell you, I have lifetime friends from these families that I've been working with for 30 plus years. So I would definitely recommend it to you as a great career choice. And with that, I am done. I will stop sharing. And Robin, what have we got in the questions?
Yeah, so thank you so much, Dr. Sommer, for taking time over here today, sharing this wonderful presentation with us. So yeah, at this time, we'll have about 10 minutes or so to answer any questions you might have directed at Dr. Sommer. So feel free to drop your question in the chat box or
all right, I'll open up my chat box here and see if I see any questions. Thank you for the kind comment, Michelle.
To start, there's a question on the direct message. What would the next step look like for gene therapeutic ideally? Would it be to reduce cost of therapy or extend usage of therapy to other different disorders or et cetera?
I would say yes to both. So two things happen. One, the development cost for bringing gene therapy through is quite high. The way folks are looking at that, though, is what is the cost under the curve? So let's take hemophilia as an example. So if I look at the annual cost of treating hemophilia with recombinant factor, it's probably close to 100,000 plus a year. So if I'm doing that for 10 to 20 years, large amount of cost. If I look at the gene therapy for that, and if theoretically it's a one-time administration, which we can get into the vagaries of that a little detailed, then I'm spending a lot of money one time. And the way the insurers are actually doing the math on this, they look at it as a cost savings for them long-term. Now, are there things we can do to reduce the cost? There's a couple of really great efforts coming along right now. One is what it's called using common platforms. So if we're using, say, adeno-associated virus as our gene therapy platform, are there ways to get approval for that as a platform so that we don't have to go back and validate it for every single rare disease we're using it in, say a particular type of AAV? So there's something called the bespoke group that's working on that with FDA and NIH and a bunch of other groups. So that I think is going to be very promising as a way to reduce cost around that. So we have to do both. I mean, the costs are very high, and as we develop more of these, we need to just kind of keep figuring that out. Like I said, there's 400 of these things going on right now, so there's definitely a lot. All right. So, all right, hypothyroidism diagnosis was possible through telemedicine was mentioned. Can you please expand on that? No, actually, let me correct that a little bit. We can identify Down syndrome through telemedicine and through our software apps. We still have to screen with a blood test for hypothyroidism. So we can't quite do that one quite yet, but I'm hoping with some of these home blood drawing systems that are very robust that we're working on right now, that we could actually then just send you a little thing you slap on the arm, you put it back in the mailer and send it back, and then we can do it that way without you having to come in. So that's something I think is going to be very promising. How can we get primary care physicians more engaged in rare disease? Well, first, we've got to start treating the whole field like we've only got these secret answers to incredibly esoteric diseases that only we are smart enough to do. There's a tendency in medicine to like, oh no, you must only be as wise and smart as I am to treat these rare diseases. Part of the problem is there's just so much of them, and it's hard for folks to figure out an approach. The data is all over the place. It's and often hard to reach places. So that last thing I showed you around the RareCAP is kind of one of our efforts to try to start bringing that back together into a more accessible way. And the other thing too is, you know, I have a lot of colleagues in Germany. I blame them because for the metabolic diseases, if you have a disease like N5, N10 methylene tetrahydrofolate reductase deficiency, just the name of the disease alone is enough to put you off from trying to figure out what's going on there. So some of it is our naming conventions. Some of it is access to good usable protocols. Some of it is us trying to realize we've got to push these things back out there. Let's see what else have we got in there.
There's a question from Sam. What steps are being taken, if any, to expand the database globally beyond the African program?
Oh, actually, tons of steps. So for instance, that facial recognition one, we've been actually validating that in the United States, Africa, South America, the Middle East, Europe, Asia. So we've actually collected tens of thousands of pictures of patients, both with and without those conditions, to validate them across different populations. So lots going on there. And globally too, around these diagnostic programs, Africa is probably the place where we have the biggest lag, but there are programs going on everywhere for that. So for Rare Disease Day, the UN Secretary General actually announced for the WHO that they're going to be working on specific items to try to do a better job with rare disease. We'll see where that goes. But I think also it's just becoming more accessible. If you reduce the cost of diagnosis, if you reduce the time to access it, and if you improve access, these things do tend to take care of themselves. All right. Can I expand a little on facial recognition? Of course I can. That's Raphael, I believe. What we mean by facial recognition is we are not doing security screens and reporting to anybody's government about that. What we found though, is there are common facial structures in the more common, what we would call dysmorphology syndromes, like Down syndrome, DeGeorge syndrome, Williams syndrome, where if we apply mathematical analysis to the face, we can't tell who the individual person is, but we can tell that their facial structure fits in with one of those conditions. Facial structure grows around a number of things. Some of it is the rate at which cells divide and move. Do they move into the proper places? Forebrain growth actually impacts facial structure as well too. Interestingly enough, humans are very good at this. If you look at someone's face, you will sort of almost instinctually know something is not quite right there. And I mean, even if it's only millimeter size changes and things like that, it's a really robust thing that's built into humans. What we've done is captured some of that into software. And the goal is to get it so that in areas where you just can't really get good diagnostics done, electrons are really cheap. But no, we're not using this to identify individuals and build a database of patients and people walking down the street, things like that. That would be creepy. Anybody else?
We don't have any more questions.
All right. Well, thank you so much for asking me today. It was an honor to be asked to participate. We'll do it again anytime you want. Robin, thank you for asking me. Michael and the rest of the team, one of the docs in that initial picture is a McGill graduate. So I've got a lot of ties up there, and y'all actually have a great rare disease program and biochem program up there.
Thank you so much, Dr. Summer, for the incredible talk. It's really, I really liked actually the ending when your take on the glass half empty or half full is really the positivity that motivates all of us. So thank you so much. So we're going to announce the winners in the chat for the Uber Eats giveaway. And so just have a look in the chat for your name, and right afterwards, we're going to be taking a short 5-minute break before our next speaker. So if you just want to stretch your legs, we'll be, right now it's about 2:05. We'll come back at 2:10 to start with the next talk.
Hi everyone, my name is Eileen Lamb and I am from the RDD chapter at Western University of Health Sciences. For this next talk, it is my pleasure to introduce Dr. Dylan Verdin. He recently earned a PhD in neuroscience from the Colorado University Anschutz Medical Campus, where he studied white matter development and stroke response in mice. Alongside his academic career, Dr. Verdin has dedicated himself to science communication, helping scientists discuss the intricacies and relevancies of their research to their peers, legislators, and non-scientists. Additionally, he has a keen appreciation for tailoring scientific information for each stakeholder's backgrounds and needs. And currently, Dr. Verdin is working as a research engagement director at a rare disease nonprofit organization that is very near and dear to my heart called kifwane.org. And so with a strong passion for science communication, Dr. Verdin is here to talk to us about the importance of effective communication in bridging gaps between academics, industries, clinicians, and patient communities. So without further ado, I'm going to hand it over to Dr. Verdin.
Thank you, Eileen. I really appreciate the invitation. And I appreciate all of your presence here today. I'm going to start with a little bit of a caveat, which is that I came into this talk a little bit nervous during my preparation because I'm brand new to kifwane.org and the rare disease network in general. And I'm coming in with a lot of enthusiasm and a lot of passion, but I want to relieve you and perhaps myself of the misconception that I am a total subject matter expert. What I am is somebody that has spent a lot of time interacting with rare disease spaces and really has a passion for understanding how communication can help us tackle common problems. And so in order to talk about that, I'd like to talk a little bit about where I'm from and an example of where communication has kind of fallen through the cracks in medical communication and finding therapeutics for rare diseases. And I then want to talk about what has been going well since. And my hope is that you'll hear some things reiterated from the talks by Dr. Hunt and Dr. Summer, which I take as a very affirmative aspect of how far the medical culture has come in integrating patient concerns in both communication and finding therapeutics that serve the people affected by disorders. So my interaction with rare diseases started very young because when I was about 8 or so, both my mother and my brother were diagnosed with autism spectrum disorder. Now, in the 90s, this was considered very rare. It wasn't in the realm of public knowledge or awareness. And it was a really big thing for my mom to discover because after a long search of characterizing her own experiences, that of my brother, and also some of the challenges that they had faced, she finally had a keyword. She finally had something that she could point to. She had autism, or more particularly, she had Asperger's syndrome. And so this was very exciting because it gave her an anchor from which to move in communication with physicians and doctors and psychologists and people in her own life. But of course, this wasn't the end of the journey for her because diagnosis is a much simpler thing than treatment. And so even though she had discovered that she had autism, I'm brought to mind a quote by Stephen Shore, an autism advocate, that when you've met one person with autism, you've met one person with autism. That is to say, there is no one descriptor of this condition or how it impacts people's lives, because autism represented a constellation of symptoms that had very distinct impacts on the quality of life of both her and my brother. And you could tell this in the way that it interacted with them as individuals, and you could also see it in the way that common descriptions of autism did or did not overlap with their experiences. And so my mom spent a lot of time interacting once she had this name, learning more about what it was to have autism. She spent a huge amount of time as a single mother with a full-time job, reading books, looking at online resources, finding community members, trying to find anything she could that would help her find ways to cope and improve her quality of life. And at the same time, she spent a lot of time interacting with psychiatrists and psychologists, both for herself and on behalf of my brother. And I wish I could say that this was always an affirmative experience, but I saw a lot of frustration in my mom through this process because many of the times she would go to a psychiatric meeting and she would come out of it and she would feel more lost than before. She said, I listed these 5 or 6 things that are happening, and they said that we would have a medication for this specific symptom, and it's not even the one that I really care about. And this was really challenging because she was trying her best to describe her journey, but she wasn't an expert. She didn't have all of the jargon, all of the words that were necessary to describe her journey and her needs. And in some cases, she went into a meeting that was following a script. And Dr. Summer has described this script as something that is kind of the old model, that the patient sits down, describes what they're going through. The medical professional says, okay, this is what you need, and we'll see you in a little bit. Let us know how it goes. This really came to a head when my mom came back from a meeting and said, I just got back from the psychiatrist, and then I went to talk to the pharmacists at the local superstore, and the pharmacist stopped me just before I walked out, and they said, wait, we've just given your son this medication, but he's also on this medication, right? And she said, yes. And they said, there is a very severe contraindication taking these medications together, and it's actually a very high risk factor. We'd like to talk to your doctor and make sure that this doesn't happen again. And this highlights a part of this journey that was really difficult for my mom, which was that in some places interacting with the medical sphere, she didn't feel heard. She didn't feel like her needs were represented, and she felt like the solutions were being imposed upon her without really taking her full knowledge into account. And luckily, there were individuals like the pharmacists who really did take her journey into account, took my brother's journey into account, and really figured out the nuance of their experience and what their needs were. And my mom really took that to heart, that there were people looking out for her. But I think this represents a couple of things that are true for other people going through rare diseases. The first is that my mom made herself an expert, both by reading, researching, interacting with others, and also just observing very closely how autism manifested in herself and my brother. And she wasn't just an expert in the subject matter, and in some cases she wasn't really the subject matter expert, but she was an expert in the stakes, and she was an expert in her goals, what she wanted for her mental health and that of my brother. And she was an expert in the priorities, what did and didn't matter the most. And those were aspects in which she didn't necessarily feel heard when she went through the medical community. She felt like she was not respected as an expert, and that she was not given chances to really voice her needs and have those needs prioritized. And so this is kind of a dark start to the talk, because this is representing, some of the challenges that people with rare diseases do face, is that they have come a long way to find a diagnosis. They have gotten the name, and the name isn't necessarily enough to give medical professionals the full context of what they're going through. And if they're kind of churned through this process without empathy, without listening to their specific needs, it can become a very frustrating context, and something that actually slows down their search for treatment, therapeutics, and solutions. And this really underlines something very important to me at a young age, which is how important it is when you are a subject matter expert to be somebody who is giving information that is specific to your audience's context. And what that really means is how important it is to listen before providing an answer, because as subject matter experts, we are individuals who can integrate vast amounts of information, but we need to be pointed in the right direction if we are trying to serve somebody. So this is something that I have seen and I've heard from other patients' journeys in their frustration with going through medicine. And I'll kind of end the darkness there, because I'll say it's come a long way since the mid-90s. And I'm really encouraged to see people like Dr. Hunt and Dr. Summer, who are really taking patient journeys and the idiosyncrasies of health into account so that we can treat people with empathy. I pursued neuroscience and psychology in particular because it was really important to me that I could understand these fields and serve as a representative to people who weren't neurotypical or who were going through their own health journeys. And not necessarily be the subject matter expert, but be somebody who understood the various types of language so that I could communicate, listen to people's needs, and also communicate them back to them how those needs could be addressed within a scientific context. I was really lucky throughout college to be introduced to mentors who gave me a lot of insight into this, into what it is to be providing contextual treatment to patients, and patients whose journeys might have been very long and very difficult. In particular, in graduate school, I was introduced to Benzie Kluger, who is a doctor and researcher studying Parkinson's disease and treating patients in the clinic. And while shadowing him, we met with some Parkinsonian patients who were really, really struggling with night terrors. And after that meeting, Dr. Kluger pulled me aside and he told me, a student who had been studying Parkinson's in rats for 3 years told me, listen, we really want to be able to treat Parkinsonian tremors. We would really like to be able to prevent people's motor dysfunction in Parkinson's. Some of these patients do not mind the tremors as much as they mind their lack of ability to sleep. In other words, their lack of ability to sleep is a bigger impact on their quality of life than the motor dysfunction. And this is really important because this was an element in which Dr. Kluger was letting the patients be an expert in their priorities. Because when he then talked about the medications, he was prioritizing ones that would disrupt their sleep schedule as little as possible. And it speaks to another mentor that I had named Dave Moen, who, when I knew him, was the president of Fairview Physicians Associates and was responsible for building a culture of physician-patient interactions that were helpful for everybody in the community. And he spoke to me about how in many conversations in the old model of physician relationships, the physician is seen as the subject matter expert and the person who's supposed to provide answers. The patients come with questions, they come with needs, and it is important for the physician to be able to step in as an expert who knows all the answers and be able to provide hope through that expertise. And the way that he was trying to remodel the culture there was that any kind of conversation about health needs to involve the patient and the doctor as peers, not necessarily that they're subject matter experts in the same thing, but that they both bring a level of expertise. And that by listening closely, a physician can learn how to specifically treat this one patient, not the disease, but how can we help this patient's quality of life? And that takes an element of slowness. Dr. Hunt spoke about how she took 10 extra minutes to read up on her patient's condition and learn how to treat that, and how sometimes in an urgent care situation that's not necessarily accessible. It's a very difficult thing to slow down and ask those questions, especially in the healthcare system that we live in right now. But I think those are very important philosophies for treating rare diseases, because when you've met one person with a rare disease, you've met one person with a rare disease. And so I took these ideas really to heart as I was going through graduate school and researching stroke from the perspective of genetically identical mice. You know, it was very much a controlled system in which to understand disease. And one of the reasons that I was attracted to KIF1A.org, where I'm now the research engagement director, is because this was a place that really respected idiosyncrasies and empathy. To speak a little bit about what KIF1A is and what KIF1A associated neurological disorder is, this is a disorder that's been diagnosed in 400 individuals across the world, and it involves over 100 known mutations in the KIF1A gene. KIF1A is a motor protein that carries cargo from one end of the neuron down its axonal projections, down its neuronal projections, to deliver various types of cargo. And when KIF1A is disrupted, either in its ability to move or its ability to bind cargo, we see a wide variety of issues occur. Spastic paraplegia, intellectual disability, epilepsy, sleep disturbances, visual impairment, the list goes on. And there's a lot we don't know about this disease because we don't know the exact cell types affected. We can say that KIF1A is a neuron-specific gene, but as somebody who studied a lot of cell types in the brain, I can say that we don't know that that is necessarily a complete answer. We still don't know a lot about these variants and how variants in different parts of the genes contribute to different manifestations of the disorder. What we do know is that when individuals come across the long diagnostic journey to find that they have a KIF1A mutation, and it is a long journey because in many cases, KIF1A isn't on standard genetic screens. And in many cases, they have been misdiagnosed as having cerebral palsy or spastic paraplegia or any number of things. Not necessarily just because of a misunderstanding, but also because it was important that these individuals got some kind of diagnostic code so that they could get insurance reimbursement, so that they could get treated and helped. KIF1A and CAND is a mutation in a disorder that doesn't have an ICD-10 code like Dr. Summer talked about. There is no code that we can point to in insurance to say this is the thing. And so much like autism in the 90s, we're dealing with something that is a constellation of symptoms. And those constellation of symptoms might be different in every patient. And this is really difficult because for many of these patients, they got to the point where they found out they had a KIF1A mutation. They found KIF1A.org and they thought, we found our community, we have our answers, we now have this source of people that we can talk about our disorder with. And they find out that their disorder may be manifesting very differently than their peers. And that's a very difficult thing. And it's very difficult because we can't give them a specific script to follow when communicating with their clinicians or their researchers. And in this scope, it's really important to understand that this is where community becomes very important, because these patients have gone through a long journey of uncertain or misdiagnosis, and they may have different capacities to engage in the work of their disorder. And it is a lot of work to have a full-time job, to be learning more about your disorder, to be communicating with clinicians. And so what these patient organizations offer is a way to spread that load and spread that load across communities. So what KIF1A.org really serves to serve in the function of is a central hub that allows communication to happen across these various groups. We have a lot of clinicians who have interacted with KIF1A patients, but they only get one or two because of the geographical dispersal that Dr. Summer referenced. And so it's really important that we can bring together a community of clinicians who can compare notes when it comes to KIF1A related disorders. We have a number of researchers who are looking into the biomechanical aspects of KIF1A mutations. And this is really important because we need to understand the mechanisms of how this disease manifests. How does it impact neuronal function? How does it lead to things like epilepsy? What kind of cell type specificity is important for KIF1A expression? We need to be talking to industry because we need KIF1A on genetic diagnostic panels. We need people to be able to get through their diagnostic journey as quickly as possible, because the sooner they know that they have a KIF1A mutation, the sooner they can engage in a more informed journey with their own health. And lastly, we need the patients. We need the people that are impacted, and we need them to be active voices in this community. And so what these organizations do and what KIF1A.org does is we collate these communities. We have a clinical community, we have a research community, we have a patient support group, and we have industry communications. And we want all of those conversations to happen as communities so that we're not just doing our own individual projects, but most of all, we want to make sure that our industry and our clinical and our research networks are informed by the patient needs. And that's one of the most important things, is we have meetings where our patients can talk and say, hey, I'm really struggling because my kid isn't sleeping, or I'm really struggling because I can't get an overnight EEG because first we need a daytime one, and I know that nothing is going to show up on that. But we can't say that because we don't have an ICD-10 code. Finding ways in which we can empower these patient voices and get them in not only amplified but consistent contact and communication with all of these other stakeholders, these subject matter experts, is really crucial for rare diseases, because we can take these idiosyncrasies and these individual journeys and we can start to find patterns And more so than that, we can ask the patients, what patterns would you like us to look at first? What are the aspects of this disorder that you really want us to be able to understand first? And what are ways that we can improve your quality of life? And in the meantime, how can we protect these patients from people that might just be offering a cure that's without context? This can happen in terms of some genetic counseling industry partners or people that are trying to provide a specific service or cure to patient communities that don't necessarily have the scientific expertise to gauge how effective this will be. And so one of the things that we've tried to step into recently is making sure that we have scientific experts who can read through and play the skeptic, so that when patients come to us saying, we're really hopeful about this, we're really hopeful about CRISPR or this specific genetic editing tool or this specific therapeutic, we can say, okay, yes, this is where the hope is. This is where our skepticism is. How would you want to prioritize this? What is the most important thing to you? What is it about this technology that speaks to you? Because then even if we don't come across that specific technology, that specific treatment, we have a better set of information to take back to our clinicians and our researchers about what it is that our patients are trying to prioritize. So with that, I just want to say that, we've come a long way as a medical and research community in engaging people and understanding them as subject matter experts. And as you go through your journey with medical education and practice, I hope that you keep in mind just how much the patient can offer in terms of information and guidance. Because as subject matter experts, the most important thing that we can do is listen, integrate, and come back with solutions that are equitable, fair, and looking forward in a hopeful way. And with that, I'll take any questions. Thank you.
Thank you so much, Dr. Verdin, for that amazing talk and for sharing with us your story. If anyone has any questions, we have time for 1 or 2 questions. You can go ahead and ask them in the chat or unmute yourself. If not, I have a question. How did you come across KIF1A, and how has your experience been there?
I was actually introduced to KIF1A by one of my graduate student associates, Tanya Brown, who works for the Test Foundation, another rare disease organization. And yeah, Tanya understood that I was really interested in using scientific expertise to help people and that I really wanted to step into science communication roles. And so, when I first engaged with the organization, I was really blown away because Dom and Kat, my individual superiors, Kat is the president and has a son with KIF1A disorder, and Kat is the science officer. I was really impressed with the level of empathy that occurred, and as they shared their resources, I found that there were conversations where parents with kids with KIF1A associated neurological disorder were talking directly to clinicians and researchers, and these clinicians and researchers were able to speak very frankly about what their scientific opinions were and how they thought we could move forward in terms of finding funding, finding clinical outcomes, finding research patterns that would actually get to serve patients as quickly as possible. And I think that level of honesty and the length of the conversations between them is something that's really, really encouraging and kind of speaks to some of these values, that it's not just a one-way street with patients waiting for a cure. It's them actively engaging in the conversation and looking for ways to enrich that process and make sure that it serves them directly, because that's the point of it all, right?
Yeah, I really enjoyed working with the KIF1A team so much. I miss them a lot. Tell them I say hi. But if anyone else has any more questions for Dr. Verdin, he can go ahead and drop his email in the chat, and then you can reach out to him. Thank you so much for spending your Sunday with us, Dr. Verdin.
Yes, thank you so much, Dr. Verdin. And I just wanted to say like the thing you said about if you met one person with autism, you've met one person with autism. It's really stuck with me, and I think it applies to like rare diseases in general and all people that you come across in healthcare. So I really appreciated your talk. Thank you so much.
My pleasure.
Hi, everyone. My name is Yehuda Al-Kaim, and I'm the co-chair of the Rare Disease Group at the Perelman School of Medicine. For the next and last talk, it is my great pleasure and honor to introduce Dr. David Feigenbaum. Dr. David Feigenbaum is an assistant professor of medicine at the University of Pennsylvania Perelman School of Medicine. He's the founding director of the Center for Cytokine Storm Treatment and Laboratory, the associate director of patient impact for the Penn Orphan Disease Center, and the co-founder and president of the Castleman Disease Collaborative Network. He's also the author of the New York Times bestseller, Chasing My Cure. Thank you, Dr. Feigenbaum, for giving us some of your precious weekend time. We're thrilled to have you with us. So without further ado, I'll hand it over to you.
Well, thank you so much for that introduction. It's wonderful to spend some time with all of you this afternoon. I've got a bit of a cough, so hopefully my message comes through despite the my voice not being 100%. So I'm going to start out by sharing my my screen, and today you're going to hear about my journey. Going from being a healthy third-year medical student, like I suspect some of you all may be in your third year, to being critically ill with a disease that I had never even heard of during medical school. So this is a picture of me. I was at the University of Pennsylvania for medical school, where I had hoped to become an oncologist one day and to treat cancer patients in memory of my mom, who had passed away a few years before, when out of nowhere, I became critically ill with multi-organ system failure. My liver, my kidneys, my bone marrow, my heart, my lungs all began to shut down for an unknown cause. I had a retinal hemorrhage that made me blind in my left eye. I gained 70 pounds of fluid, drifted in and out of consciousness, and eventually I was so sick that my doctors didn't think I would survive. And a priest actually came into my room and read my last rites to me. I've really considered that moment when a priest was in my room reading my last rites to me to be the start of an overtime being time that I didn't think that I would have, where I've really tried to make the most of every second. Fortunately, at the last possible moment, the diagnosis was made, a lymph node biopsy was performed, and the doctors diagnosed me with idiopathic multicentric Castleman disease, which is a rare immune system disorder where the immune system attacks and shuts down your vital organs for an unknown cause. There are about 5,000 patients diagnosed each year in the US, so it's about as common as ALS. Unfortunately, about a third of us will die within 5 years of diagnosis. Another third will die within 10 years of diagnosis. And for my particular subtype, many of us do not survive past a year. And though there were no FDA-approved drugs, my doctors decided to try a combination of 7 chemotherapies in a last-ditch effort to try to save my life. And thankfully, they worked. Here you can see my dad by my side. He actually never left my side throughout my entire illness. And you can see I've lost my hair and I've got a big belly because my liver and my kidneys were not functioning. But I was just so happy to be alive. This picture on the right is from New Year's Eve, 2010. So at this stage, about 5 months into my illness. And I was so thankful the chemo was working. But again, you can see this big belly. And on New Year's Eve, my dad and I went for a walk around the hospital. And as we passed the family waiting room, we saw there was a gentleman who looked like he was drunk on New Year's Eve. He had clearly been drinking too much. He was kind of swaying in his chair. And on our next lap around the hospital, we saw that he had fallen to the ground. And so my dad ran over to him and helped him back into his chair. And he looked at my dad and I, and he said, "Thanks so much. Good luck to you and your wife." He said, "Wife? What is he talking about?" And then I looked at my belly and I realized he thought that I was my dad's pregnant wife, which was a low point emotionally for both of us. But we laughed so hard. And that's when I learned just the power of laughter in the midst of really tough times, laughing with the people that you love. So this picture was taken about 7 weeks later when I was finally discharged from the hospital after over 6 months hospitalized. And you can kind of see how someone maybe would have confused me as my father's pregnant wife with a really big belly from the liver and kidney failure. And then this is a picture from a few years before. I played college football at Georgetown. I was a quarterback there. And I always say these are like the worst before and after pictures of all time. But if we could flip the order, they could be this amazing advertisement for Peloton or Mirror or Muscle Milk. But unfortunately, the pictures are in the wrong order. I did take a picture every week for the next 8 weeks, and you can see my hair starting to grow back. You can see the fluid starting to go away in my belly, and I look less like my father's pregnant wife by the end. There really were two things that kept me going when I got out of the hospital. The first was the love of my life, Caitlin, who I dated for over 3 years and who I dreamed of maybe one day having a family with. And the second is actually in that bag around my shoulder. So in the bag is an experimental drug called siltuximab. It's an IL-6 blocker, and it's being pumped into my port and through a line and then infused in my body. And at the time, it was undergoing a clinical trial, and it was the only drug, still the only drug, that's ever undergone a randomized controlled trial for Castleman disease. And I hoped so badly that it would work for me. And I remember my doctor explaining to me that, you know, this was our hope that we'd been waiting for. This was the drug that was going to really be the answer to everyone's prayers. But unfortunately, about a year after starting on it, while I was back in med school and back in my 4th year of med school, I relapsed while on this drug. And I learned that I was now relapsing on the only drug in development. There were no more promising leads. And unfortunately, I would continue to relapse, and we would have to hope that that same combination of 7 chemotherapies could save my life. But unfortunately, or fortunately, the chemo did work. Unfortunately, I nearly died now for the 4th time with this relapse, and chemo just barely saved me. And so I turned to my dad, my sisters, and Caitlin, and I promised them I would dedicate the rest of my life, however long that may be, to trying to find a drug that could maybe save me and patients like me. So I got involved in research. Like I suspect many of you, I went in medical school expecting to be a clinical physician, and I really had very little experience with research. But at this stage, the world didn't know how my disease worked. And so I knew that my only chance of survival would be to get involved in trying to find something more out about this disease. No one was studying Castleman disease at Penn, but a pulmonology researcher gave me some space in her lab and let me go to work. And so I started doing research on my own samples, but I knew it was unlikely that I would make progress in time to save myself. And so I created a foundation called the Castleman Disease Collaborative Network with the goal of bringing together physicians, researchers, and patients from around the world. And as I dug into the field, I learned that very little progress had been made over the previous 50 years. The drug that I had been on, that experimental drug, was actually based on a discovery made 25 years before, and there had not been a single discovery like it, identifying a new therapeutic target in those 25 years. There was no diagnostic criteria, no treatment guidelines, and very little progress. So I knew that we had to take a different approach than had been taken historically, and we did. We decided that first, rather than raising money and then inviting researchers to apply for that funding and then picking the best applicant, which is really the traditional way research is done, we said we want to build a community of physicians, researchers, and patients, turn to that community to prioritize what research should be done, and then go out and recruit the best researchers in the world to actually do the work, to get away from this request for proposal model towards this collaborative network approach model. And secondly, we knew that we needed to identify what was going wrong in the immune systems of patients like me. But we also knew that we didn't have the time or the resources to develop a drug from scratch. If we could figure out what was going on in the immune system, we would then need to match it to an already FDA-approved drug that we would be repurposing to treat Castleman disease. That was really our only shot. And so let me explain what I mean by repurposing. Well, first off, there are about 10,000 human diseases. And those 10,000 human diseases, there's about 2,500 drugs that are approved to treat these diseases. Since most drugs are approved for between 1 and 2 diseases, and since many diseases have multiple drugs approved for them, it turns out that we've got about 2,500 drugs that are approved for about 2,500 diseases. So there's about 7,000 diseases that don't have any approved therapies. And so for me, I knew that really my only hope would be to identify one of those drugs that was already approved for something else that could maybe be repurposed to treat my disease. So this concept is not unique to medicine, the concept of repurposing. The very first telephone was actually intended to be a hearing aid. The first radio was meant to be for ships to communicate with other ships. And the first computer was actually built to track results from the US Census. And of course, we all know that these three discoveries have all gone on to have many, many more uses. Similarly, the drug thalidomide, which you all have probably heard of, was first developed as a morning sickness drug, and it caused horrible birth defects, but was later determined to be a powerful cancer-killing drug for multiple myeloma. The drug Viagra, which many of you all are familiar with the primary use, is also used for pulmonary arterial hypertension, a rare pulmonary disorder. And the drug tocilizumab, which was initially developed for Castleman disease, though it did not work in my case, it's also an IL-6 blocker. That drug is actually the first drug you receive anywhere in the world if you were admitted to the ICU for COVID-19. Tocilizumab, this Castleman's drug. And so while these drugs really demonstrate the promise of drug repurposing, unfortunately, they're really the exceptions rather than the rules. And unfortunately, this does not happen in many cases because about 90% of all approved drugs are already generic, which means that there are no incentives for companies to do the work to figure out new uses for these existing drugs. And so really with all this in mind, I returned to medical school. I kept pushing forward my research. I eventually graduated from medical school. This is me on my med school graduation day. And I got engaged to Caitlin right around that time. We hoped to make it to our wedding date, May 24th, 2014. And I began business school at Wharton because I realized that some of the greatest challenges for progress for Castleman disease were actually organizational problems, managerial problems. And I thought that an MBA would help with some of that. But unfortunately, in the midst of the progress we made for Castleman disease, developing a diagnostic criteria, developing treatment guidelines, launching studies, I relapsed and I nearly died for the 5th time. Again, a combination of 7 chemotherapies saved my life just barely, but I knew that I wouldn't make it to our wedding date of May 24th, 2014, unless I found a drug that could maybe save my life. So from there, I went on to perform a series of experiments. First, I performed serum proteomics on my serum samples that I'd been storing in the weeks leading up to my relapse. And I was able to determine there were a number of cytokines, in fact, a number of chemokines that were highly elevated in my blood when I relapsed. I also found that a protein called VEGF, or vascular endothelial growth factor, was also quite elevated. And notably that there was really increased T cell activation from doing flow cytometry on my peripheral blood mononuclear cells. And so these were 3 interesting findings that had not been described before in Castleman disease. And based on the association between how they changed leading up to my relapse, I thought that they could maybe be playing a role in my disease. But I wondered, could there be a central pathway involved in all of these things that maybe could be druggable, maybe something we could hit with one drug that could knock out each of these things? And went back to the proteomic data and determined that there was a signature suggesting that the mTOR signaling pathway could be involved in my disease. Now, interestingly, mTOR is critical for VEGF production, it's critical for T cell activation, and for your immune cells to communicate with one another. It's a key communication line. So it kind of fit the bill, but we really had to confirm whether mTOR was actually activated. So I performed a study called immunohistochemistry, where I measured the levels or the activation of mTOR in a number of normal lymph nodes. And so brown is positive, blue is negative. And you can see in this normal lymph node that most of the cells in a normal lymph node do not have the mTOR pathway turned on. Most cells are blue, negative. They're not brown or positive. And then I performed the exact same study on my sample, and I was really just blown away by how much mTOR activation was occurring. The communication line was clearly turned on in my case, and I wondered if maybe inhibiting it could be helpful for preventing a relapse. And fortunately, about 50 years before, on the island of Rapa Nui, researchers had discovered in the soil a potent inhibitor of mTOR. It's called rapamycin or sirolimus. It's a great inhibitor of mTOR. And it went on to be developed and approved for kidney transplantation. It helps to suppress your immune system. And no one had ever imagined it could be used for Castleman's. But here I was, 50 years later, armed with data that suggested that maybe this treatment could be useful for my disease, for Castleman disease. And without any other options, my doctors and I decided that we should try it. So today marks 97.68 months that I've been in remission, and you can look on the graph and kind of see what the average length of remission was in my previous 4 relapses or previous 4 remission periods. But I say 97.68 because I know that I can't round up. I don't know if this drug is going to work for 98 months, but I also refuse to round down. I'm just so thankful for every fraction of a week, a month, a day, a year that I have while I'm on this drug. And during this remission, the New York Times called this "Doctor Cure Thyself," which I think is a bit of an overstatement. I think it should be doctor helping himself a little bit right now and hopefully for a lot longer. But unfortunately, I don't think that would have fit on the headline. But really importantly, during this relapse, Caitlin and I made it to our wedding day, May 24th, 2014. 3 years ago, we had our first child, Amelia, named after my mom, same initials as my mom, AMF. And just 3 months ago, we had our son. And as I look at these pictures, I think about where things are right now. It feels like a total dream. I honestly can't believe that that I'm alive for 97.68 months, and that I've got this amazing family. And so when I joined the faculty at the University of Pennsylvania 7 years ago, I decided to make it my life's mission to identify treatments so more people can live out dreams like this that they never thought they could live longer lives than they ever imagined. Of course, with the goal being that every patient with Castleman disease, with a related disease, and of course, even with all rare diseases, can live a full life, both in quality and quantity. And that's really what I'm committed to every day with my work. So once we figured out the sirolimus helped me, we started thinking about giving it to other patients. And so we've given it to patients like Katie and Deepa, Clara, Jacob, Joey, have all gotten the drug and they've all benefited, and many patients like them have benefited from this treatment. It's just been amazing to see, a drug that I initially found in the search for a treatment for myself, and to watch it help other people. It's just been unbelievable, but it hasn't helped everyone. Patients like Kyla spent a year in the hospital in Chicago. Nothing worked. Chemo, IL-6 blockade, sirolimus, nothing was working. And just a couple of weeks before her doctor called me, we'd made a discovery in the lab that a particular communication line called the JAK-STAT signaling pathway appeared to be hyperactivated in Castleman samples as well. And so we encouraged her doctor to try a JAK inhibitor. And Kyla, fortunately, has been doing really well for over a year and a half. But we've also looked beyond Castleman disease. So when Michael was diagnosed with metastatic angiosarcoma, and his doctors explained to him that there were just he had a few months to live and that there were no more options, we went to work, and we ended up finding out that his tumor appeared to be susceptible to a cancer immunotherapy that had never been used before for sarcoma. But the data was really strong, and we actually were able to convince the drug company to provide the drug for free. And Michael has been doing well for over 6 years in remission. And now patients all over the world with sarcoma receive checkpoint inhibitors, just like the one that we got Michael on. Now, despite our full efforts and all the work that we do, we're not able to help everyone. Patients like Lisa and Elise and Joseph, who battle Castleman disease, and despite every drug we try, they don't survive. And it's these patients that drive us to continue to push forward with everything that we have to find more solutions for patients like them. And it's really that sort of drive that led us to launch the Corona Project when COVID-19 emerged, and we saw that there was no central effort to track all the treatments being used for COVID, and that unfortunately there was so much devastation occurring with this virus. So we launched the Corona Project in March of 2020. In fact, a number of medical students from around the country joined our team to try to identify all treatments being used for COVID and to apply an algorithm across all the data to identify the most effective or promising treatments to then be included in large clinical trials. And so the Corona Project data has served as the primary data source for clinical trials launched by the federal government, like the Active-6 trial and the CDRC's trial. So it's served as this central resource, and I hope you all will check it out and let me know if you're interested in getting involved in any way. So you can imagine, that I'm alive because of a drug that's repurposed. We've been able to demonstrate the benefits of these repurposed drugs. In fact, the 2 drugs that have saved the most lives during COVID are dexamethasone and tocilizumab. Both drugs are repurposed and used for COVID. And of course, no one thought about using them for COVID when this whole thing started. So you can imagine that I'm just so dedicated to figuring out how can we figure out a way so that every patient that could benefit from an existing drug actually does. And so one of the ways is through raising awareness. And as was shared at the beginning before my talk, I wrote a book about my journey called Chasing My Cure. And that book has helped to raise a lot of awareness about this concept of drug repurposing. In fact, I got a phone call from President Clinton recently because he wanted to talk about the potential for drug repurposing. And I got a chance to meet him in person and to talk to him about this, because I think it's a really, really important opportunity for us to really make a difference against disease globally. So in addition to raising awareness, we also realized we need to map out, how do you do this? It's not easy. It wasn't an easy process to get from where we were to where we are. And so we launched the Roadmap Project a couple of years ago. And that's another project where we have a number of volunteers from around the country who are helping to map out what's the process of drug repurposing? How can you find new uses for old drugs? And then third, I think there really needs to be an important data play here. We've got to get away from where there's 2,500 drugs for 2,500 diseases. And in the same way that we found new uses for Castleman disease and COVID, we've got to leverage all the data available to really make sure that our 2,500 plus drugs can really be used in many more ways. And you're probably well aware that every new drug costs about $1 billion to develop. It takes about a decade. So, it's going to be a while before we have a new drug for all 10,000 diseases. What we need to do in the meantime is to utilize our existing drugs in new ways. So I just want to close with a few lessons from my journey that I hope will resonate with you all. And as was shared earlier, I wrote this book because I learned so many lessons about life and hope from nearly dying 5 times that have really fundamentally changed who I am. I was a medical student when it happened, so you can imagine I spend most of the book talking about medical school experiences and challenges that I faced and how those really informed my search for a cure. But I'll just share a few of those lessons now. So the first is that I talked at the beginning about feeling like I was in overtime, but the reality is we're all in overtime. All of us really need to make the most of every second that we have. The second is that I hope no one watching is ever confused as your father's pregnant wife. But if you are, I hope you can find some humor in that and all of life's challenges. I found that laughing with the people you love can be really, really powerful. Third, you have to turn hope into action. My life changed when I started hoping for things and also acting upon those things that I was hoping for. The fourth is that solutions can be hiding in plain sight. The drug that I'm on that's saving my life was sitting at my neighborhood pharmacy for years while I was in and out of the ICU, but no one had ever thought to try it. How many more drugs are just sitting at your neighborhood pharmacy that could be a treatment for you, one of your patients, or someone that you love? And then finally, my book is called Chasing My Cure, but I really think it should have been called Chasing Our Cures, because it hasn't just been me. It's actually been a huge army of people working on this. Every year for the last 6 years, we've had an amazing Penn Med student take a full year out to work with our team. For the first time ever, we're actually opening up that opportunity to medical students all over the country to take a year out and spend it with us. We've had patients, physicians, researchers, people from all walks of life that have been a part of this effort. And so I really hope all of you will become part of this army that's working to try to drive forward science and research, drug repurposing, and I hope that you all will help to spread these messages. I hope you'll take it back to how you take care of your patients, take it back into your own lives, and do send me an email if you're interested in learning more about this fellowship. It's a year out project with us. We basically involve you in all aspects of everything we do, and we provide a $32,000 stipend for the year, and just are looking for someone really, really wonderful. Like I said, it's been a Penn Med student the last 6 years, but for the first time ever, we're opening that beyond Penn, and are eager to see who might be able to really fill this important need of doing a little bit of everything from research to communicating with patients to writing guidelines for how do you treat diseases. So I hope that this has been helpful for you guys as you think about the next steps of your career. And I'm just so thankful that this organization exists that can shine a light on rare disease. So thank you guys so much.
Thank you so much, Dr. Feigenbaum, for your inspiring talk.
Yeah.
And we'll open it for questions. Please feel free to either unmute yourself or put them in the chat.
And I love seeing the comment. So that means that you could actually hear what I was saying, which makes me feel good, because the whole time I've been talking, I'm thinking to myself, I hope you can understand what I'm saying, despite this laryngitis that I've got going on. So there's a great question about policy and regulatory changes that could help to expedite reusing drugs for new diseases. This is something that we've thought about a lot over the last 6 years. I was a part of proposing a bill called the Open Act that basically would have made it so that drugs that are approved for one disease, if you can get them approved also for another condition, in fact, a rare condition, that would give you 6 more months before your drug becomes generic. It's a way to incentivize companies to look for new uses. I think that just is kind of the tip of the iceberg. The bigger problem is that 90% of drugs are already generic, so you can't apply legislation like that. There are things you could do, like potentially saying if you could find a new use for an existing drug that's already generic, can you provide some sort of a voucher? So maybe some financial prize or award to the company that figures that out, maybe a voucher so that the next time you apply for a new drug, you get accelerated access. These are the kinds of things that we've thought about. But Eva, if this is something that you think about, we would love for you to think about it with us and share your thoughts. I'm alive because of a repurposed drug, and I really feel like I owe the universe to try to do the best I can to try to make it so this happens for more people. So I really do mean it when I say, like, please do email me if you are interested in anything that I talked about today, especially repurposing, COVID, Castleman, cytokine storms. We almost certainly will either have a position that you might be able to get involved in, or would just love to share ideas for how to tackle these problems. Oh, thanks for all these nice comments. So there's a great question from David around how do you figure this out? What's the best way to find new uses for existing drugs? And my experience is that there's been a lot of high throughput drug screening, which is basically where you drop like 7,000 different compounds on a bunch of wells of cells, with the idea being that maybe if you test drugs in a dish, that you'll get a sense for what looks like it's going to work or not. And unfortunately, hundreds of millions of dollars have been spent on high throughput drug screens with very few successes of new uses of existing drugs. So I'm much more a proponent of this idea of applying all these really cool new technologies like single cell RNA sequencing, serum proteomics, to better understand what's going on in the disease, and then ask what drugs are already approved that can fix the problem. Is there too much of something? Is there too little of something? And is there a drug that can make more or make less of that thing? And then you start testing those drugs in some sort of a model system. But you realize that model systems like in vitro models or animal models, they're not perfect. And so I'm much more proponent of this sort of data-driven drug repurposing, where it's, you generate data on the disease, you match it to a drug, and then frankly, the proof is in the pudding in terms of giving it to humans. You can model these things all you want, but it's not until you give an mTOR inhibitor to a Castleman's patient like me that you know whether mTOR inhibition is going to work or not. And so that's not always easy to do. And of course, I was the patient, so it was a little bit easier to test it on myself than I don't know if I would have felt comfortable yet, because I had very limited data to test it on a patient other than myself. But these sorts of things are really important. It's about matching things together and then figuring out how can you rapidly and safely test these things in humans. And David, I'm just reading the second half of your question. What I just said is exactly what you suggested. So yes, that's exact. I totally agree with you. So then, yeah, there's a question about the ethical approval for the research I did. So one thing that really surprised me when I was a medical student, and maybe you guys already know this, but I didn't realize that about 30% of all prescriptions are written for things that that drug is not approved for. So all day long, 1/3 of the prescriptions that you're going to write are going to be for a disease that that drug's not approved for. Now, most of those 30% are for things that everyone kind of knows. Oh yeah, sure, you can use that drug for this disease. That makes sense. It may not be approved for that, it's approved for something else, but it happens all the time. What I'm describing is like the first time a human with my disease has ever gotten this drug, which obviously happens much less commonly, but there is no research requirement to do that. You know, once you can write a prescription, you can write a prescription for any drug for any disease you want. You know, you could write a prescription to use chemotherapy for toenail fungus if you want. You know, the drug company or the insurance company may not reimburse it, but you can write any prescription for anything you want once you're a doctor. Now, an important question is the ethics around the research that led to that, you know, trying sirolimus. And so we had an IRB approved protocol, just like any protocol that one of your PIs may have. And it said we'd be using samples from Castleman's patients. And of course, you know, I happened to be doing the research and happened to be the patient, but the Penn IRB was really supportive of the fact that as long as I was transparent and I included other people in analyses of the data, that it could be done ethically.
I just wanted to thank you so much, Dr. Feigenbaum, for your talk. It's so empowering, and I think that it really got me to reflect on, you know, the way that we do research, especially about repurposing drugs and seeing things not just from the way they always have been, but really taking an approach that it's very creative, and I found it very inspiring. Thank you so much.
Thank you so much. I really appreciate it. And thanks for organizing and coordinating this. It's so important that med students learn about rare diseases and focus on this. So as a rare disease patient, thank you guys all so much.
Thank you. And if you'd like, you can put your contact in the chat. That way, if anyone has questions, they have it as a reference there. And so we'll go on to continue the event. Just before that, Yehuda, did you want to just talk to us a bit more about the book draw?
Sure, yes. So we have 10 books that we will give out. And once the winners are announced, we will get them shipped to you.
So thank you so much also for this donation, Dr. Feigenbaum. And I really think that events like this are the opportunity for us to connect and exchange ideas and really learn from the people we want to hear from, the patients, the researchers, the health professionals, and it's really a group effort. So thank you so much. On this note, we also have, as usual, the Uber Eats draw, which will be announced in the chat. But we also have another very kind, generous donation of a book called Summer's Complaint by Laura Feger. I don't know if she's here, but if you're here, would you like to give a few words on your book?
Can you hear me okay?
Yes.
All right, great. Well, I'm not a doctor, but I am the mother of a doctor, and I'm also the author of Summer's Complaint. I grew up in a family with a rare hereditary cancer syndrome called familial adenomatous polyposis. And it chronicles my family's journey over several generations. And it's important to talk about, again, the patient experience, the family experience, and in our case, the many years of dealing with a very difficult, complex cancer syndrome. So essentially, I come from a cancer family. And as a result of this, my son grew up watching and listening and learning, and it inspired him to go into medicine. He was in med school between 2008 and 2012. And then he went to residency at Johns Hopkins in radiology, and today he's a interventional radiologist. I'm very proud of him. But I bring that up also because he wrote the afterword. He wrote the afterword of the book, and you know, it was a great way of bringing our story around full circle. The last thing I'd like to say is there's a line or a byline in the movie Gattaca about there is no gene for the human spirit, and that is my family. And I'm really happy and honored to be able to talk about the book briefly and enter it into a book giveaway. So thank you.
Thank you so much, Laura. That's very, very kind of you. And we look forward to hopefully having you in future events to talk to us more about your journey. Thank you so much. So with this, we'll just give a brief word about rareDIG before we wrap up. First, I'd like to thank everyone who attended today. It's really a pleasure to have you. And it's really thanks to you that we have events like this. Otherwise, we'd just be talking to ourselves. So thank you so much for those who are speaking and helped share the event. Just briefly, I'm going to talk a bit about rareDIG. So we're really a group of medical students who were founded in 2017 at McGill. And Kristen Hunt did a great job of explaining in detail and how this started. And, you know, it's really, really incredible to see how far it's come, especially that we now have chapters across North America who are joining us today. And our goal is to shape a generation of physicians to give a platform for people with rare diseases like we are today. So we have many events every year, and I'm not going to read them out, but these are just a few of them listed here. So you can get more information on our website, which is below, and we'll also put it in the chat. So you can reach out to us, and we'd be happy to discuss more and help to give you more information about future events. So with that, I want to really thank everyone. Like I said, thank you to our speakers who gave such empowering talks today, really helping us reflect on what we can do and how we can be involved to help raise awareness and make a change in the lives of those with rare diseases, because it really affects all of us. And we all play a part in this. So I'm incredibly motivated. I'm sure we all are as well here who joined today. So thank you so much. Thank you also to the Student Union for sponsoring this event, helping us give away those prizes, and for the generous book donation by Dr. Fagenbaum and Laura Krieger. It's very kind of you. And we will be reaching out for those who won the book draw. We're going to be getting some information to help deliver it to you. So I'll be reaching out to you by email. So just look out in your email if you're one of the winners of the book, so we can deliver it to you. Finally, I'd like to thank the entire team here at McGill. It's really, none of this can be done without a strong team, and it's really what we have here at McGill and with our chapters. It's, I want to thank everyone. I want to thank you all for sharing the event and helping this be a very successful educational experience for all of us. So thank you all. I'm going to leave the event open just for a few minutes for those who want to exchange contact info in the chat. And if anyone else would like to give a final word, please feel free. Otherwise, I'm going to just leave the chat open. And thank you so much again.